Hello, thank you all for your attention. My name is Jason Cuellar. I'm an orthopedic spine surgeon. I've been practicing in LA for the last 6 years and now transitioning over to South Florida in Miami and Palm Beach Gardens. I'm going to talk today about lumbar disc replacements and pushing the indications. So currently, I'm calling myself a spinal arthroplasty surgeon because that's what I'm really passionate about. That's what I'm mostly doing these days. And I'm really focusing on this aspect of my practice. So I do have some disclosures. I have been paid in the past by Sentinel Spine to do pro disc surgeon education courses. So I really want to talk about the anti-arthroplasty surgeon excuses, and I'm sure a lot of you in the room have heard these too many times, like the disc space is too collapsed, there's a spondylolisthesis, the facet joints are too arthritic, the patient is too old, and the last one really bothers me because some of these surgeons are considering patients that are 65 too old to have arthroplasty. Well, that makes no sense to me. A lot of these patients are physiologically young, they've just retired, they want to golf and ski and do all sorts of things. So I'm going to show you some examples of some older patients like this 74-year-old female that I had with multi-level spondylosis, discogenic back pain, lumbar radiculopathy, and most surgeons are going to do a multi-level fusion on this patient. L2 to the pelvis possibly is going to end up, or they might do from the beginning a T10 to the pelvis. Well, I really think that that's going to be bad for this patient long term. I ended up doing only a two-level fusion and an arthroplasty above to stop that cascade. Here's another example, 72-year-old female, severe degenerative disc disease, L5S1, L3-4, stenosis L3-4, neurogenic claudication, back pain, leg pain. She's already fused her L4-5, but look at the 2-3, she's got some degeneration already. If you just fuse 3-4, what's going to happen to that 2-3 to her in a couple of years? Or if you have to fuse L3 to S1, what's going to happen? That's going to turn into most likely a T10 to the pelvis, right? So I was able to do this all from the front, and she's doing amazingly well. She already fused the 4-5, so I didn't need to do that level. Did ADR at the top level, 2-3 above the L3-4 spondylolisthesis, where I was able to fuse that one all anteriorly. I did do a little decompression posteriorly at L3-4. She did great. So I'm not just thinking about tomorrow with these patients, I'm thinking about 10 years from now. I really want to avoid this cascade that we're seeing all the time in spine surgery. I really think it's bad for patients. So here's a couple examples I'm going to give you guys. 66-year-old professional stuntman. He's still working. He's got axial low back pain. He's done all these Fast and Furious movies. We don't see him in the movie, but he's behind the scenes doing all these car crashes, and his back is really messed up. So you can see every single lumbar level and above completely collapsed, bone on bone, not much motion there. But he's pretty straight, no scoliosis, no rotatory problem. You can see the MRI, multi-level collapse, but not really much lateral recess stenosis. And on a CT scan, every level is very collapsed, but the facets really don't look bad. I'd call it, mild to moderate facet arthropathy. So this is one of those levels where most surgeons are going to say, "Oh, he's too collapsed. You can't get this space open." Well, if you really work at it carefully, do your releases, get your spreaders all the way to the back, you can really get these open. Be really careful with the end plate and make sure you release fully before you jack up the space using a spreader with a lot of force. But you can see the L5S1 level very tough. You can see the release going on there with the angled curette. And I was able to eventually get that open. Had to use a David spreader, but eventually got it. So this is an example of very, very collapsed disc spaces that I was able to get open. And he's doing great. Back pain's gone. He went back to work very quickly. And had I done a multi-level fusion, I don't think he would have. So there's another example of a slightly older patient, 66-year-old, active man, ex-military. He did not want a fusion, but he's got radiculopathy and low back pain, and he's got a spondylolisthesis. So you can see at L3-4, but it's only grade 1. L4-5 is also collapsed, but it's relatively stable. A little bit of motion on flexion, but not much. You can see the MRI. He's got severe lateral recess and foraminal stenosis at that level, not so bad at the level below. CT scan shows, I'd call moderate to severe facet arthropathy, some mesial osteophytes causing lateral recess stenosis, and not as bad at the level below. So we were able to do 2-level lumbar ADR in this patient at those 2 levels. I did turn him over and do decompression to get rid of those mesial osteophytes. I don't think an indirect decompression would have done the trick fully on that patient. He's now almost 3 years out, no complaints. You can see the spondy still there a little bit, reduced a little bit, but it's not unstable, not causing any problems. 65-year-old artist bodybuilder with low back pain, axial back pain. You can see he's pretty straight, a little bit of tilt, but not much. Break collapse, lower 3 levels. MRI, 3-level disease. CT, 3-level disease. But look at the facets. Facet joints are fine. This is a guy in excellent shape. Does he really deserve a 3-level fusion? But how is he going to get rid of his back pain? Back pain is killing him. So I really don't think that we should ignore these patients or fuse these patients. This is another case, very collapsed, able to get it open. L5S1, again, at tough level. You've got to make sure you get rid of that posterior hook off of L5 after you do your release. Get the spreaders all the way back posteriorly before you open them up. And by the way, this was done outpatient. We have shown with a number of the surgeons in the room with you guys that we were able to do these safely outpatient. We did a study, 200 patients, 100 inpatient, 100 outpatient, showed very similar outcomes. And so we believe we can do these safely if the patient is well selected outpatient. Another example, 38-year-old male with history of 3 prior microdiscectomies, back pain, leg pain, recurrent disc herniation now. You can see left-sided L3-4 recurrent disc herniation, right-sided L4-5 herniation, and then left-sided L5S1 herniation. The guy's 38. He wants to surf. You know, he's got very collapsed L4-5, pretty collapsed L3-4 and L5S1. So what are you going to do with him? Look at the CT scan. Left-sided facet arthropathy. Previous surgeries took out, a bit of that facet on the left side. Previous surgeries took out both facets, L4-5, pretty significantly. So this one, I'm gonna do a hybrid on. Now, so I fused that L4-5 level that had trash facets on both sides, but was able to do an ADR at the 3-4 level where he had unilateral facet problem, and then gave him motion below. So he's got motion above and below. I think long-term, this is going to be much better for him than a multi-level fusion. And he's doing great. He is now 3 years post-op, leg pain completely gone, both sides. Back pain is doing great. Another patient case, 55-year-old gentleman, severe leg and back pain. Notice he's got some lateral translation with some pelvic obliquity. This is a case you got to be very cautious of trying to do an ADR. You see that lateral translation. I'm worried about trying to do an ADR at that level, even though I pushed indications. I've had one backfire, and that's the case that's going to get you, I think. So this case also did a hybrid, and you can see we ended up with a stable platform above that fusion, corrected the deformity, and he was able to have an ADR at the top level. Young patient, I'm looking, once again down the line, 10 years down the line, want to prevent that adjacent segment degeneration. Right. Another case, 56-year-old gentleman pilot with chronic low back pain. I put this case in there for the facet arthropathy that you see here. Left side facet, he had an old fracture there, so he's got some damage to that facet joint. But there's no instability on flexion extension, right? So we were able to go ahead and do the ADR even at that level, and it didn't cause him problems. He actually was doing so well, he didn't feel like coming back for x-rays, but I found his review online. He says he's totally pain-free a couple of years out. So the facet joints don't always cause a problem where they're at the higher levels. I wouldn't do that L5S1, but L3, 4, 4, 5, I think are okay. Another example, 49-year-old male, 3 years of radiating low back pain. You can see he's got a very minimal spondylolisthesis up there. He does have a facet, some sort of facet pathology. Looks like a facet fracture type of a pathology at that one level, but he was able to tolerate an ADR without a problem. He's now 3 levels. So I really think you can push indications with unilateral facet issues. Even I've done pretty severe facet arthropathy patients. So motion preservation, it can be done, but you have to be careful, obviously, and always get dynamic X-rays. Always check the bone density, get a pre-op CT. If you've got facet issues or facet pathology on CT, warn the patient. They may need some treatment, but I still think it can be done. So I really appreciate everyone's attention, and I look forward to seeing you all in the future.